Good afternoon. Welcome to today's presentation, Shifts in Illicit Drug Use Heighten the COVID-19 Health Crisis. This webinar series is made possible by a grant award from SAMHSA, the Substance Abuse and Mental Health Services Administration. We are excited to provide this virtual series during the month of September, which is National Recovery Month. Today's session is being recorded and will be uploaded to the CMH YouTube channel for future reference. Please feel free to use the chat box to ask questions and add comments you have at any time during this webinar. And if time allows, we'll do our best to answer as many as we can at the end. Our presenter today is Dr. Kelly Olson. Dr. Olson is a neuroscientist, author, and keynote speaker who believes that assessing and addressing disease requires an integrative approach. She received her PhD in pharmacology and therapeutics from the University of Manitoba. Currently, she holds the position of Director of Clinical Affairs at Millennium Health, which is one of the largest toxicology laboratories in the United States. Here she focuses much of her attention on mental health, particularly with an emphasis on addictions. And with that, I will turn it over to our presenter.
Hi, everyone. Clearly, I am a neuroscientist and not a tech person, so sorry about that little delay at the beginning. But thank you so much for joining us today. It's my pleasure to be here to present to you guys. I wish I could see you all. I wish we could be in a room so that we could, have some good cross-pollination with questions and different things. But at the end, as was mentioned, we'll leave a little bit of time so that if you do have questions regarding this data or anything else you may have heard, then we'll address that at the end. And I am up actually in the Upper Peninsula here in Michigan. So I'm in my mobile office, as you can see, and it's a little bit windy. So hopefully you aren't going to hear too much noise and the car won't start going back and forth. But just so happy to be here. My background, I started off in law enforcement. And so I kind of had, I'm going to say, a little grittier view of addiction. I had a lot of people that I would deal with that weren't always telling me the truth. And I know you tend to see that too from time to time with patients and clients, but it was a little bit different. Back then, when I was in law enforcement, obviously I wanted to keep myself safe as well as protect the public. And so it was a different angle than from medicine. And I've spent the last 11 years now in integrative medicine as a neuroscientist. So kind of on the other side of the coin, if you will, where I learned that, okay, there are times where people aren't necessarily coming clean with you, telling you everything that there is. But in this particular capacity, I find that I'm aligning with my patients and my clients, and it's a different way of looking at things. It's not a punitive way, if you will. It's a let's align with our patients and let's see what we can do to ensure their success in recovery. And so it was a different, I had to learn a lot. And I'm the first to admit that at the beginning, I wasn't very good. Obviously I had that training really, entrenched in me. And as I moved through time, I hope I got a little bit better and learned that a lot of this has a lot to do with the behavioral side as well of addiction. So what I want to present to you today is where I am employed, so Millennium Health. And again, as that disclaimer, I'm the director of clinical affairs. But as part of my job there is to take data that we receive in those seeking care, mostly from urine drug test results, take that data and turn it into what would be trends, what would be more hot areas, if you will, for substance use. And then to turn that data back into the hands of the folks that are in the trenches like yourselves. And so it's not just a testing company, but also a solutions company. And I'm not very good with business, so I'm going to stick to clinical, but I just wanted you all to know that that's where I'm coming from with this presentation. So if we look at My next slide, this is something that we're all very familiar with. This was just the latest information from the CDC that was released, and it looked at overdose deaths in total for the nation. And most of you have read this already, 93,000 deaths due to drug overdose in 2020, projected to reach a new record high. Well, those projections are in, and those numbers sit, like I said, right around that 93,000. Absolutely astounding in terms of drug overdose deaths. And we have to also keep in mind that we are in a time of a pandemic. And so last night I was up in Sault Ste. Marie, Michigan, and they were asking, why in the world are these numbers going up when we're in the middle of a pandemic? And the answer is, and a lot of you already know this, is that there's not one answer. There's many, and some of it though has to do with the anxiety, certainly the depression, the feeling of the unknown, the fact that a lot of these substances that folks are using are already here in our country, even though the borders at one time were closed, and we'll talk a little bit about that. But somehow those numbers, those overdose death numbers, just keep climbing. And so we'll talk a little bit more about that as we sort of push through the data this afternoon. But certainly just keep in mind that oftentimes we may not know all the answers. And so we can speculate, we can have a really good idea, but there are often times where we don't have all the answers. And so if we look at this, this is another study, if you will, looking at time on that x-axis, and you can see that there along the horizontal from 2000 to 2019. So it's still fairly recent. This is data that was done by National Center for Health Statistics, and again through the CDC. And then you can see the drug overdose deaths on the y-axis up that far vertical side. And you can see what they're looking at here: heroin, methamphetamine, prescription opioids, cocaine, and synthetic opioids. And that primarily includes fentanyl. So it just kind of gives you an idea of what the CDC is seeing across the nation. As we go through this presentation, you'll see that we get a little more specific than just the nation. We also get specific to census divisions as well as state. But let's look at it basically across the nation. So if we look at what we'll really focus on today with methamphetamine, synthetic opioids, cocaine, heroin, and prescription opioids, let's look at the orange line. This is the synthetic opioids in terms of drug overdose deaths over those years. And this synthetic opioids, for the most part, as I mentioned just a few seconds ago, is primarily fentanyl. So look at over time, you'll see that fairly, I'm not going to say flat trajectory. It's got a slight uptick in it over time. But look what happened in about 2013. We see this massive increase in overdose deaths with synthetic opioids. And again, I wish this surprised us, because it would mean that it's something that we aren't dealing with at this point, but we're in the thick of it. That number continues to rise for these particular classes of substances. If we look at methamphetamine, the yellow line, you can see a similar trajectory upwards, and then around 2012, 2013, we saw that drug overdose deaths due to methamphetamine increase significantly as well. Certainly, as we look at things like cocaine, we've got a bit of a different trajectory here, and then an increase around 2015, and that's leveled off somewhat. And again, keeping in mind, this is just before the national declaration of COVID-19, but you can see the trajectory across the nation of these overdose deaths. Heroin, same idea. We've got a bit of a slight upwards trend. 2010, we saw a very high trend in overdose deaths due to heroin, and then a little bit of a leveling off. That's not to say that heroin or any of these substances where we may see a bit of a leveling is not contributing to some of these deaths. We just see that things like synthetic opioids, methamphetamine have sort of taken the lead in a lot of these things. And then again, if we look at prescription opioids, which we'll talk about a bit later on today, you'll see that there is a slight decrease here as sort of more of the current times, if you will. So one other thing I wanted to show you guys, and this was something that really struck me. If you look at the penny in the middle of the screen, or just kind of middle of the screen, and off to the right of that is a little bit of powder. This is just a visual perspective, if you will. This is from the DEA, and this is 2 milligrams of fentanyl that you see in front of you, which would be considered a lethal dose in most people. So we talk about those synthetic opioids, you see that massive increase in overdose deaths, and then you look at just the amount that it takes for a lethal dose for most people, and you can well appreciate how potent, how powerful this substance is. And we'll do a fair bit of speaking on fentanyl as I move through this presentation. So that kind of sets the stage, if you will, for what we'll be speaking about today. Absolutely every one of those substances that we mentioned, I will touch on. And in some cases, I'll get a little bit more in depth. Methamphetamine is no exception. This is something that at least orientates ourselves to where methamphetamine is coming from, how long we've had these issues with methamphetamine in our country, that sort of thing. So just allow me to take you on a little bit of a journey here. If you look to the far left of this timeline, 1893 is when methamphetamine was first synthesized. So it was synthesized in a laboratory. And what's interesting about a lot of these substances that find their way onto the street is that they started for, I'm going to say, more benevolent reasons. I don't know how many of you've heard of the illicit substance called spice or K2. That started off in the lab as a way to make a pill for someone who was having a really hard time with appetite during chemotherapy, for example, or those with AIDS that had a really hard time with appetite. They could take this pill, this spice varietal. I mean, it's called spice now colloquially, but synthetic cannabinoid, and it would help with appetite. Well, things like methamphetamine, synthesized back in the 1800s, started off as something that would give people just a little bit of energy. And I say that very cautiously because it wasn't designed to head out to the streets right away. It was designed to help people with a bit of energy. And you can see in the 1940s, it was used by soldiers in World War II. So again, something that helped with putting a pep in someone's step, getting some of that energy back into life. Then in the 50s and the 60s, it was sold as a popular diet pill. This is where things started to get a little bit gray, a little bit wobbly, if you will. In the 1970s and 80s, methamphetamine became a Schedule II drug. And not only that, once it became a Schedule II, it had a high street value. And so we see a lot of motorcycle gangs getting involved with the trafficking of this substance. We see a lot of meth houses, as they were again colloquially called, springing up, and people were creating their own methamphetamine. And again, this isn't something that's new. We knew this for years. Back when I was in high school, they used to have these billboards up. I grew up in a very small town, but I remember seeing this billboard. So it was something you didn't miss, especially in a small town. And it had a dual picture, a split picture of the same girl. On one side, it was a picture of this very vibrant, very happy-go-lucky looking young person. And again, it was in front of our high school. And then that same billboard on the right-hand side had a picture of this very ragged, hopeless look in the same girl's eye, and then it said methamphetamine can kill on this billboard. And so that was the first time I had really heard about it, and certainly it had been around for a very long time at that point. And so obviously we knew that it was starting to get deeply entrenched in our communities. So having methamphetamine around is certainly not a surprise to us. But again, we know that it is certainly steeped in so many of the drug trafficking channels right now that it is almost impossible to find a place in anywhere in the United States that hasn't had some dealings or some issues with methamphetamine. And you can see in the 90s, the illicit use exploded. And then after that, we started to look at the border, obviously increases in drug seizures, etc. So by 2017, methamphetamine became the most common drug identified by law enforcement. And you can read pretty much any newspaper from any larger city, especially border towns, where you'll see that there are these massive, and I'm not talking about just a few pounds, we're talking about hundreds of pounds of these substances, methamphetamine included. So it is definitely something that we know has been here for a while, but I don't know how many of you know this. We know that the younger sort of generation of the cartels, if you will, have really, really been drawn to methamphetamine manufacturing. So a lot of what we used to see manufactured here in our own country has now been taken, either squashed or eliminated in some way or another. And now the younger generation of the cartels have really gotten on board to traffic methamphetamine, provide it to their, their dealers here in the United States. Now, we got to be careful not to single people out. I understand that. We definitely see most of the methamphetamine coming into our country coming from the South. So we do have to at least acknowledge that. Now, if you look at the top picture where you see those red buckets, those 5-gallon pails, that's all liquid methamphetamine. And so what we're finding with that is that for the most part, it's a little bit easier. I'm going to say not easier to traffic per se, but if you put it into those 5-gallon drums as a liquid, oftentimes it can look like cooking oil or motor oil, and the manifest that goes along with the semi-truck can reflect that as well. So it's quite easy to get that through, especially with essential travel with the borders. That's something that obviously only a few months after the pandemic began, we started to see this essential travel was being approved. And so things like agriculture, things like, goods and services were still available, but as an essential part of, sort of that realm. Well, that meant goods were coming up from places in the South. And so we do have to keep that in mind. Now, the other thing is that liquid methamphetamine would be brought to a warehouse here in the United States, and it would either be sold as liquid methamphetamine, not all that often, but it was still available to be sold as such, or it was distilled down into powder and then basically put into circulation that way. So they had very, very complete plans, if you will, on what to do with that liquid methamphetamine. Now, the bottom picture that you see, you can see these are pills here at the bottom. They look like Adderall pills. And when I say they look like, to the naked eye, we even had pharmacists looking at clandestine pills or these lab created pills versus the actual pharmaceutical. And to the naked eye, it was very difficult, if not impossible, to determine what substance they had. Was it a real or was it the fake substance or the fake pill? Now, it was, if you put it under a microscope, you can detect the jagged edges around these pills, but to the naked eye, they've gotten very good at pressing into what looks like a prescription. So what you see there on the bottom right-hand side, that's actually methamphetamine masquerading as Adderall. And you guys have heard this many times over, I'm sure, with things like oxycodone pills being full of fentanyl, for example. This is not new, but certainly these are more engineering ways, if you will, to get substances into our country. So speaking of that, if we look at obviously how these substances are getting into our country, let's talk about potency and price as well. So for methamphetamine in 2007, it sat at around 56% pure. And the price per gram, and that was sort of the weight of choice for this particular analysis, was about $152. If we look at 2017, it was sitting around 97% pure as the highest purity that you could get your hands on. Now, that doesn't mean every dealer has 97% purity, for methamphetamine, but That was about as high as you could get, which is exceptionally pure. It was down to $56 a gram. So you can well appreciate that the potency goes up, but the price goes down. Now we've got a perfect storm. And you'll see this as well when we start talking about fentanyl. So speaking of which, let's get right into that. So for the most part, the fentanyl that we're talking about is still mostly coming in from China, from clandestine labs there that are producing this illicit fentanyl. So they're not necessarily producing pharmaceuticals for us, but it's the illicit fentanyl um, demand, if you will, that is pulling from China. We're also seeing that the cartels are getting on board as well for that, and they're starting to bring the creation or the manufacture of fentanyl in-house, if you will. So kind of cutting out China and then bringing it into their own channels again. But at this point, China still remains one of our top suppliers of illicit fentanyl. If you guys look on the far right hand, the top right hand side of the screen, you'll see 3 vials sitting there. Each one of those vials is exactly the same size. They're about 2 inches high and about the diameter of your index finger. What you'll find with this is that it's purely a visual. So I don't know about you guys, but I'm very visual. This was very poignant when I looked kind of at the conclusion of what this picture is showing us. So if we look at the far left here, we'll see that heroin in this first vial, there's a set amount of powder of heroin in this vial. So think of it like a potency comparison, if you will. Beside it is the exact same vial, only this time it's filled with fentanyl. And as we know, as you can see here, fentanyl is 50 to 100 times more potent than morphine. So it has quite a variation there. To get that same potency of heroin, you would need basically just a little bit of that fentanyl powder, not much. And given the picture that we had with that penny from the beginning of the presentation, you can well appreciate why. If we look the far right of this picture, there's a substance there written called carfentanil. Now, I don't know how many of you know about carfentanil. I'm sure you've heard of it. It's a veterinary medicine that is used to down large animals, kind of like an elephant tranquilizer, if you will. It's about 10,000 times more potent than morphine. It does not have any human medical uses at this point. It's strictly for animals, but somehow it found its way into the drug trafficking channels because it had such a high for a very, very small amount. And you can see that. If you look at that vial, you can see one little granule of carfentanil is equal to that same amount of, or potency of heroin. So again, very rudimentary, but I just wanted to give you guys a visual as to how powerful some of these synthetic opioids are. And we'll talk a little bit more too about, we call them fentanyl analogs or fentalogs, if you will. We'll discuss a few of those as well in the next sections, but I just wanted to draw your attention to these top 3 because certainly we're not seeing as much carfentanil anymore, thankfully, but absolutely, fentanyl for sure, and then heroin as well. It's not gone away. And you can see here as well that in our published study, we identified carfentanil in about 3% of fentanyl positive specimens. And we saw this primarily in northeastern Ohio. So that was, and we cover the entire United States, but that's where that hot pocket was for carfentanil. And then the second most common analog not associated with fentanyl metabolism itself, or synthesis, if you will, is called acryl fentanyl. And we'll discuss that a little bit as well. There's 2 substances, acryl and acetyl fentanyl, that we're seeing a little bit more of on the streets today. Those are, again, about as potent as fentanyl itself. So that's something that we'll, to keep in mind, but we'll talk about that in the next section. So before we dive right into the data, one last thing I want to bring your attention to is cost and return on investment, just so that we can hammer home how important these substances are to drug trafficking because of the return on investment. So let me just walk you through this. So if we looked at heroin, And we looked at around a kilo, basically, purchased from Colombia, which isn't always the most common place that we're getting heroin from. Most of it's coming from Mexico, but we also still have Colombia as a supplier as well. And we look at a cost per kilogram of about $5,000 to $7,000. The revenue from that kilo of heroin is in the ballpark of about $80,000. So that return on investment alone is something certainly not to sneeze at. Oh, that's a terrible pun. I'm sorry about that. It's certainly something that is it's no small potatoes. $80,000 is a lot of money. But if we look at pure fentanyl sitting at about 99%, and let me tell you, fentanyl in the street is not always that pure, but this was just for our analysis. And most of that coming in from China, as I mentioned before, around the same purchase price, around that $5,000 cost per kilo. Guess how much revenue comes from that kilo of pure fentanyl? Just think about it for a second. If 80,000 from a kilo of heroin, what would it be for pure fentanyl? And I hope I surprise you guys, but upwards to $2 million. And that to me is absolutely astounding. You need less of the fentanyl to get people high. You need less of it for so many other reasons, and you make much, much more money off of that. So you can well appreciate the absolute draw behind both methamphetamine and fentanyl in our society today. So let's dive into the data that we talked about or that we discovered. We do these or present these dossiers, if you will, called Signals Report. We also have published in JAMA as well, which is one of the top medical journals of our days currently. We've published a lot of this data there as well, but this is a little more long-term, if you will, and a little more focused on COVID. So we looked at it from a broad angle, and then we narrowed in the focus as well to look at that time frame of last year when, March 13th was that national declaration. So we looked at 3.5 million de-identified definitive urine drug test results. Now, one thing again to keep in mind, and I mentioned this a little bit earlier in the talk, was that these are all in patients seeking care. And so it's a little bit different than maybe what you would see on the street, but if they're coming to you and they're seeking care, there could have, obviously some reflective nature in the two populations. So, but just keep that in mind. It's coming from those seeking care across the entire United States, all 50 states. And it was collected January 1st, 2013 through December 31st, 2020. So that was our large analysis, if you will. But we also looked at positivity rates during the pre-COVID, what we call pre-COVID, March 13th, 2019 to December 31st, 2019. And then the COVID time periods of March 13th, 2020 and December 31st, 2020. So a year apart, basically. And those with prescriptions, with reported prescriptions, were excluded. So that kind of gives you sort of the foundation, if you will. This is what we found. On the x-axis, the horizontal axis is time, 2013 to 2020. On the y-axis, or the vertical, adjusted positivity rate. And each of the four substances, methamphetamine, fentanyl, cocaine, and heroin, were chosen for a reason. This is what most of our facilities are seeing in terms of what they're fighting against. Also what places like the DEA are identifying, certainly Border Patrol as well are confiscating. So we went with these four substances for this analysis. If you look at heroin, the black line here, you'll see that it obviously had some ebbs and flows. And you can remember that first slide that we were showing, or the second slide, I should say, but what the CDC had presented on this. Heroin ended up having a little bit of a spike. This dotted line is that declaration, national emergency, March 13th. 2020 for COVID-19. You can see there was a little bit of a dash of a positivity rate. This is not death rate, only positive urine drug tests. And then it decreased after that quite quickly back to its pre-COVID levels. Now, cocaine is the yellow line. You can see a little bit of a different display for cocaine, but similar in terms of its kind of almost like a sawtooth, but more of a general positivity rate. And then it too increased after that declaration was set. And then those positivity rates in those urine specimens decreased back to pre-COVID levels. But let's look at fentanyl and methamphetamine. There's a very different story here. Fentanyl is orange, so let's follow that. A bit of a plateau, then an increase in 2015 for positivity, another slight plateau, another bump in positivity. But look what happened. We had a constant trajectory upwards since about the end of 2018, beginning of 19. After the declaration of COVID hit, it increased significantly in terms of positivity, and that positivity rate has not decreased. It has not gone back down. If anything, it continues to rise slightly as we move past that declaration time. If you look at methamphetamine, the blue line, again, very different presentation here. We've got a constant trajectory upward in terms of positivity since about 2003, at least from when we started the analysis. But look what happened here right when that declaration was set. We have this, again, increase in positivity for meth, and it has not gotten back to its pre-COVID levels. So these substances are very much still with us. They were very much here in the country when the pandemic hit as well. So people had access to these substances. But once again, you know, for trafficking, we need people and we need movement. So once both borders opened up to essential travel, we had both. We had people and we had movement. If we look at this now, we're going to kind of pinch in the time frame that we studied here. We're looking only at COVID time periods right now. So March 13th to December 31st, 2020. I wish I could say it was over December 31st, 2020, but it isn't. We're clearly still in it. But the analysis went until the end of last year. So keep that in mind. If we look here, fentanyl, methamphetamine, heroin, and cocaine are listed. The darker the red in these heat maps, the more positive the results are. And again, it was just that, 8-9 month period there that we were dealing with. And you could see from March to December, for example, fentanyl in the East North Central region increased almost 9%. In the East South Central region, same idea. If you look at methamphetamine, and certainly, you know, you can pick out as well where in these census regions you are, or maybe have family or friends, or maybe you're from some of these other census regions. Methamphetamine, if we kind of look in the middle of the country as well, you can see the darker the red in the West North Central, 12% increase, the East South Central, almost 14% increase in positivity. Most of methamphetamine, just so you guys know as well, are certainly being targeted to the West. Now, people in the West say, oh, we've had methamphetamine here for a long time. We're not being targeted. Well, you are, in the Western United States especially. And the reason why we say that is because, yes, it was there, but now it's they're considered more of a new market for methamphetamine. And fentanyl is kind of moving back upwards into the east and sort of into that Atlantic region as well. Now the mountain region's being hit too, but it's kind of, you can see this movement. Now you may not see that in your practices, and I suspect that to be true, but if we look at it from a nation, if you will, you can see where that increase in positivity is happening. And cocaine and heroin is listed in the bottom. For cocaine, we do see a fair increase here in this East North Central region as well of about 6%. If we look at it in terms of more of a wider view, so from 2019 to 2020, so now we're looking, instead of around 8-9 months, we're looking at a year. You can see various regions again for fentanyl, methamphetamine, heroin, and cocaine. The darker the red, the greater the increase in positivity. And if we look at some of these regions here, the mountain region, you know, where Colorado, Nebraska, those places are, increased 125% for fentanyl positivity. In the Pacific region, down along the coast, the West Coast, you'll see an increase of about 180% during that time. If we look at some of the Atlantic regions, the South Atlantic increased about 26%, and so on and so forth. And you can see that as well. The West North Central increased about 58% as well. So the numbers just are obviously backing up what we're seeing with our patients and our clients. And you can see that as well with methamphetamine. And look at this with the New England region, 119% increase in methamphetamine positivity during that time frame. So what we did from that point is we went a little bit farther down and we looked at it by state in terms of positivity during that year period. And you can see here the top states for fentanyl. Ohio is right here at 68% in that fentanyl positivity, state specific, so not census region now. Michigan, where I am right now, 145% increase in fentanyl. If you look over here with methamphetamine, again, you can see those various states. Just because you may not see your state there does not mean that it's not obviously in your state, but certainly these particular states saw the greatest increase. Look at Virginia, you guys, at 336% increase in methamphetamine positivity. Nevada, 324%. And again, it's that time frame, that 2019 to 2020. So what this basically is telling us is that these substances are very much in our midst, but certainly methamphetamine and fentanyl are leading the charge. And one last sort of, I guess, comment for this particular section is we know there's no antidote for methamphetamine, at least no FDA approved medications that are specific to that. And so if you've got someone who has a methamphetamine use disorder, or they're with polysubstance use, they've got an opioid on board, plus a stimulant, in this case methamphetamine, we know we've got FDA approved treatments for opioid use disorder, but we don't for methamphetamine. Now, that's not to say that some clinicians aren't utilizing some treatments, absolutely. But in terms of FDA approved medications, we don't have that. And so if we've got a patient or a client who are using both substances, and we do see that from time to time, opioids may be the drug of choice, and they utilize a stimulant as to kind of keep them awake, kind of take the edge off, if you will, of the more sedative feeling. On the flip side, if they're a stimulant user and they don't like that sort of crawl out of your skin feeling that can sometimes occur from a stimulant, they'll put an opioid on board, and that'll kind of tamper that down a little bit, or tamp that down, if you will. Some people have no clue that they have those substances on board. They only decided to do heroin. They didn't bargain for having methamphetamine, or vice versa. Or they only wanted to smoke marijuana. They didn't bargain for having it laced with fentanyl or laced with heroin. So we do have to keep in mind that sometimes they know and they're their own chemist, and other times they haven't got a clue. So let's look at carfentanil. We'll do this really, really quickly. Again, I want to remind you of that visual of the penny with fentanyl. So you'll see that little bit of powder there as a 2 milligram dose. And you'll recall we called that fatal dose for a lot of people, for the majority of people. Well, let's look at carfentanil. And you remember I described that to you as to what it was. You'll see that little tiny bit of powder there right by Lincoln's chin. Not very much. It's about 0.02 milligrams. That would be considered a lethal dose for most people for carfentanil. So again, just to orientate yourself to that, we certainly have a lot of articles that have been published on this substance as well. But very, very quickly, let me just tell you what's going on in that realm, if you will. So on the x-axis, again, we've got date, August 2019. probably July 2019 to the end of 2020. So again, we're looking at that pre and post-COVID time, post-COVID national emergency declaration, to clarify. Someday I hope to be speaking to you guys, like I said, and saying that COVID is over, but we're not quite there yet. So if you look at carfentanil, this orange line here, you'll see that back in 2019, it was sitting at around 4% positivity rate across the nation. That's not insignificant considering how potent this particular substance is. Over time, and again, you'll see that dotted line in the middle as that declaration moment of March 13th, you'll see this massive decline in the use of carfentanil. Now, whether that's a supply issue, we don't know exactly, but it went down to basically zero. Now, you know this better than anyone. When something goes out of fashion or something gets something interrupts the supply chain, you will see that something else will take its place. Now we know that fentanyl is certainly still very much in there. You can see that blue line indicating that. But look at this black line here. This is acrylfentanyl. And if you think of these fentanyl analogs, think of the fentanyl molecule itself. This is kind of like the backbone of the fentanyl molecule. When chemists change the chemical bonds in that backbone, they can create other substances. And that's where these fentanyl analogs come along. Now, acrylfentanyl is no exception. It's one of those man-made or synthetic analogs. And you can see that it has increased in its positivity over time across the nation. And it's sitting at probably just under about 1%. So it's still a very, very small number for percentage for that particular synthetic opioid, but still, it's still around. It's something that we do deal with, and know that you can test for it. But certainly those instant read cups, the point of care, you may not be able to pick up the analogs with that. So just keep that in mind. Think about more along the lines of definitive testing, which that's what you're seeing in front of you right now. So if we look at section 3 of this particular report, I'll get a little more in detail with this. So this is really looking at prescription opioids. And you'll recall from that slide that I presented near the very beginning that prescription opioid overdose deaths have decreased. And I'm going to kind of set the stage here for what we saw as well that corroborates with that based on the data that we were able to obtain. So we certainly know that misuse and overdose deaths involving prescription opioids declined, which we just talked about. Hydrocodone combination products were rescheduled in 2014, if you recall, and so that made a difference as well. Tramadol confiscations were up 145% since 2014, and it is now the 12th most confiscated drug in 2014 in terms of the pharmaceuticals. And that was from the US Drug Enforcement Administration. And controlled substances may be prescribed without in-person interaction for the duration of the pandemic. So we also know that things in terms of the landscape have changed since being in this pandemic. And so if we look at the results from the analysis that we had or that we did based on, again, people seeking care, urine drug test results, this is what we found. So we've got time on that x-axis again. We've got adjusted positivity rate on the y-axis here. And then just like the previous section, we've got 4 substances broken down by color. So gabapentin, oxycodone, hydrocodone, and tramadol. And so let's start out with oxy and hydrocodone. So the yellow and the orange colored lines here, you can see that over time, and again, these are non-prescribed positivity rates of these substances. So keep that in mind. You can see a decrease across time, a few little blips here and there, but more of a downward trajectory in those positivity rates. A little bit of an increase after that declaration, that dotted line, and then a decrease back to pre-COVID levels in terms of positivity. Let's look at gabapentin. Now, some of you may be, it may be a substance that you're dealing with right now in terms of non-prescribed use with your patients and clients. What we saw in terms of positivity rates was an increase around the end of 2015, kind of a sawtooth over time, a very gradual sawtooth over time, and then a bit of an increase again here after the declaration, and then back down to pre-COVID levels. But look at tramadol. So the black line that you see right here, you can see a fairly steady plateau of tramadol positivity over time. But look what happened at that during that time of the declaration of COVID. We saw this increase in non-prescribed tramadol positivity. So it kind of works in conjunction with what I just said on that previous slide about the increase in confiscations. So it is something to watch for. Certainly we're keeping our eye on tramadol as well. Might be something, again, that you want to kind of keep at least in the back of your mind. We certainly saw an increased positivity significantly in tramadol, non-prescribed, primarily in Tennessee, Ohio, and Kentucky. So those were the top three, if you will. They remain steady for gabapentin despite some fluctuations. So we are still hearing across the nation about crushing and snorting gabapentin or taking in, large quantities of the pills themselves. And we have not, things have not changed significantly for hydrocodone and oxy, which you saw in that previous slide. So I think that that's also an important piece to at least just keep in mind. And actually, obviously, like I said, it's something to celebrate. We are seeing these, non-prescribed positivity with some of these opioids decreasing, but then there are some that are kind of following in the wake of that, if you will, and that's things like tramadol. Last section I wanted to describe to you guys or walk you through is really dedicated to methadone maintenance. So there were some unexpected findings here, and it may raise some risks as we look through this data. So certainly in your practices, what you may see, some of you may be using methadone as well as a maintenance. So this particular section may be of interest to you. So a little bit of background on methadone for those of you that may not be utilizing it in your practices. It's commonly used, most of us know, to treat opioid use disorder. It's also known to improve patient outcomes. There's a lot of positivity with methadone maintenance. State and federal agencies have eased the restrictions, obviously as a pandemic thing. They've eased those restrictions on take-home methadone for stable patients during the pandemic. Now, things change as that pandemic unfolds or as the current pandemic unfolds. But obviously we saw a change in some of these restrictions, more of an ease in stable patients on take-home methadone. So what we did was we looked at a number of different, again, urine drug test results, specifically in those that were prescribed methadone. So 2020 positivity rates and percent change for 12 substances in the population prescribed methadone. So this is a little bit different than some of the other sections. We're now talking about prescribed methadone, and we're looking at 2020 data only. So along the x-axis here, you'll see a number of different types of medicines, a number of different types of substances, as well as things like cocaine, marijuana, fentanyl, heroin, alcohol. And so when we look at these substances, I just want to give you an idea. There were 12 of them that we measured, and they were all listed there. So that kind of orientates you to the slide. And then the adjusted positivity rate is here on the X or the Y-axis or the upright axis. Now, the methadone, the way we set it up, methadone prescribed, if they were negative for their prescription, it was in blue. If they were positive for their prescription, it was in orange. So that also orientates you to the slide. So in those that were negative, we saw certainly that hydrocodone was certainly something that would potentially be positive in about 2% of the time. If we go all the way to the other side of this graph and we look at those that were negative for their methadone, they had the propensity toward having more fentanyl, more marijuana, more cocaine, if you will, at that point. So if they were negative, there was a much greater chance of having another substance on board. And I'm sorry, just to be clear here, if they were negative for their methadone, in the cases that we analyzed, 75% of those had a greater risk for fentanyl. So that's how to read that. So sorry if I wasn't clear. For those that were on their methadone in that case, I'll just move the chat box out of the way. Those that were positive had a much decreased or less risk of having fentanyl on board. So let's look at marijuana here. Those that were negative for methamphetamine, or negative for their methadone, for marijuana, they had about a 38% chance of a higher risk for marijuana. And those that were positive, it was slightly less. So the bottom line is that those that were taking their methadone, if they were being maintained on methadone, had less risk of taking in another substance. That, however, wasn't the case across every substance. So if we look here at gabapentin, for example, it was almost equal in terms of those that were taking their methadone and those that weren't, the propensity toward having gabapentin. Another one that was quite similar as well is if we look here at alcohol, it was fairly similar, although a little bit more for those that were negative for their methadone. So that's how to read this. Marijuana, again, just like we talked about, a little bit similar as well. So the bottom line with this methadone study that we did is that those that were more, that had their prescription on board, that had methadone there, they were less likely to have something else on board. So just, I want to make sure that that I say that correctly. 90% of those not taking prescribed methadone, but 50% of those taking methadone were also positive for 2 or more non-prescribed or illicit substances. And you can see the top 5 there in front of you. So please hear me, those that are taking their methadone prescription were less likely to have another substance on board, but it was not completely 0%. And so about 50% of those taking their methadone also were positive for 2 or more substances. So there's something to celebrate there. Certainly it's a positive toward the efficacy of methadone, for example, but there's also pause, and like everything else, we can improve, and that there are some folks that still are positive for their methadone, but we're still fighting other substances with them. Now, some of them are fentanyl, some of them are opioid related, but there are other substances like methamphetamine, marijuana, cocaine, and gabapentin, and we know that those substances do not appreciably affect those opioid receptors where methadone has its, primary focus. And so a lot of times folks will say, look, I'm taking my methadone, but they're going around and they're getting high with another substance. So that's that other percentage, that 50% in our demographic that I'm talking about. So bottom line, methadone obviously is helping a lot of people, but there are still people that we have to be really careful about because they are bringing other substances on board. So just in summary, I know we're almost to the top of the hour. We've got about 5 minutes left to go. So let me just summarize everything here. But we know that during COVID-19, certainly fentanyl and methamphetamine increased significantly. We know that. We see that in these numbers. We see that in our patients and in our clients. Carfentanil, thankfully, has dropped sharply. Now, I would love to say that it's gone indefinitely. Obviously, other things have come, into play, but I just don't know if carfentanil is gone completely. I have a feeling that that's something that potentially could be waiting in the wings. Tramadol has increased significantly, and again, as we talked about, primarily in Tennessee, Ohio, and Kentucky. Hydrocodone, oxy, and gabapentin have essentially been unchanged, especially in that time frame that we were testing. But there are some unexpected findings that are common in those that are prescribed methadone, and we talked a little bit about that, with higher rates in those that are negative for methadone. So one more time, we've sort of hit that one out of the park in terms of what we're looking at for medication maintenance. And then substance use trends likely to evolve during the pandemic. And that's something that we'll continue to also monitor to be able to put this data in your hands. The pandemic has done, and you know this, has done so much to us behaviorally, obviously mentally, emotionally, spiritually, all of those things. And it does continue to sort of bleed over into everything we do, whether it's helping our clients and patients with their treatment, helping them once they're in recovery to find ways that they can continue to be successful in their recovery. It's just added another layer of complexity to what we do. And then near real-time urine drug test data can help monitor drug use trends. And I think that's an important piece to this as well. You have tools at the ready to be able to monitor your patients and clients and to help them, with their treatment. And so with that, I know we've got about 3 minutes left, and I wanted to see if anybody had questions, or, Sarah or Karen, if you guys saw any questions in the chat that I can help answer, and then we can go from there. So if anybody has questions, feel free to put it in the chat. And if I don't have the answers, I will find them and we will get them to you for sure. So Karen or Sarah, do you?
It doesn't look like we have any questions yet in the chat. So I don't know if there's just any, other takeaways that you want to expand on just a little bit. We'll give people a second here to type in anything they might be thinking on.
Yeah, absolutely. So remember we talked about at the very beginning, and a little bit partway through as well, we were talking about polysubstance use. Just so you all know, it's really interesting to me. I speak to clinicians all across the country, certainly more focused in the Midwest and the West. And what I'm finding, and I don't know if you are as well, but what I'm finding is that very rarely are we dealing with one substance. So, and what I mean by that is that very rarely do we have a client or a patient that presents to us with one substance positive in a test result. And so many times we see polysubstance use. And so again, I don't know if you're seeing that as much, but I'm telling you, I can count on one hand in all of the places I've been to in the last probably 2 months where there's been a patient with one substance on board that they're dealing with. And so we're definitely challenged when we're providing treatment for our patients and clients for that reason, many reasons, but that one seems to be pretty deep seated, is that we're not just dealing with one substance here, we're dealing with oftentimes 2 or more substances. So keep that in mind as well as you work through sort of patient intake, client intakes. Like I said, you're probably doing this every day already, preaching to the choir. But it does complicate treatment on a lot of levels because we're dealing with more than one substance. So that's one other takeaway that I wanted to present to you all. And the last one that and again, we're about a minute before top of the hour, but the last one is also, now that we're coming into cold and flu season, if I can say that, coming into the colder part of the year, watch for things like cough syrup, dextromethorphan. That is certainly a substance that we're seeing from time to time misuse of as well, dropping a little string into the cough syrup, and then if it's one of those white cotton strings that get dropped in, the dextromethorphan basically attaches to that string like rock candy, and people just can eat that candy and become high, euphoric, I guess is more of the way to describe it, from that dextromethorphan. And the last one I'll mention to you guys is Imodium. Still around, it's still being utilized to basically overwhelm those peripheral opioid receptors and get a little bit of a high in that central nervous system. So 2 things I just kind of wanted to leave you guys with that we didn't talk about in the actual presentation. So with that, are we at the top of the hour? I don't want to keep you, everybody's so busy, but if there's any questions.
Thank you.
Yep.
Yeah, thank you so much. So we didn't have any other questions in the chat.
Okay.
We had a comment from one of our clinicians here, Carolyn. She just said awesome training, and she kind of echoed what you were finding, that she's also found many individuals using multiple substances during COVID, kind of using whatever was available. So just kind of similar to what you were talking about there. But I just want to thank you so much for your time and all of your fantastic information and data today. And thanks to everyone for joining us on this webinar. Today's presentation was one of many webinars scheduled throughout the month of September. We still have 3 left next week, and you can still register for these at sccmh.org. At the conclusion of this session, a pop-up will appear on your screen with the survey. Please take a minute to fill this out and give us your feedback. Thanks again for joining us today, and we look forward to seeing you all at the next webinar.
Thanks, everyone.